will be presented to you this morning from both campuses. And so before I continue our conversation, because I want to wrap up myself, I'm going to turn it over to our Research Day coordinators, facilitators, the ones who made this possible for us for today. That is Dr. Anna Potter and Beth Gilbert here in Fort Lauderdale. So Dr. Potter, if you want to introduce yourself and the day, and we'll turn it over to Beth. Thank you.
Thank you, Manal. Yes, I'm pretty sure, I hope everybody knows who I am at this point, right? And you've been emailing me a lot too for research opportunities. Great, let me know if I can help you with anything, okay? And Beth
Dr.
Gilbert.
Potter, give us 1 second because we can't really hear you too well.
Okay.
All right, and you want to start again? And my folks here in Steele, if we could please quiet down.
All right, we'll try this again, because I know you guys are all really excited to start listening to some talks and seeing some posters. So hopefully you guys all know who I am. I saw you for Biochem. Yay, Biochem. But today we're doing a very first of its kind, where we are hosting a research day to celebrate DO students and their research. And this is being streamed between both campuses at the same time. You're going to see talks from students on both campuses. And you're going to have poster sessions that you're actually going to go and see for both campuses. And so this is a really great day to look at research, get an idea of what a conference looks like, too. So if you don't have experience with ever going to a conference, or presenting a poster or a talk, this is a really great way to learn about what the rules are, what professionalism is at a conference. So we are going to have student talks, the poster session, and then we have an amazing keynote speaker for you at 11 o'clock. He is going to be down in Fort Lauderdale, but it will be streamed up here in Tampa as well. So we are really excited for this day, and let's throw it on over to Beth for anything she would like to say too.
Right, I'm not the most technologically advanced person. Good morning, everybody. I am Beth Gilbert. Thank you all for being here today. I just wanted to start out by thanking Dean Wallace for her support of research efforts across both faculty and students. It is all the faculty and students here within KP that have advanced us significantly in terms of research that guides your clinical practice. I'd also like to thank Dr. Kleinis, and especially I'd like everybody on the Tampa campus and here in Fort Lauderdale to give a big round of applause to Dr. Potter for really putting this out there. Great job. This is going to be a wonderful day and a wonderful event, and like Dr. Potter had said, this is really going to give you an idea of all the types of research efforts that are going on here, the scholarly activities that are going on here among students. And I'd also like to thank you all for being engaged in research, curious, innovative, and really trying to understand how research guides clinical practice. So with that, we are going to turn it over to the Tampa campus, who is going to have our first speaker for the day. So thank you everybody for being here, and I hope you have a wonderful day.
Yes.
You have your first speaker then.
Yes, we do. We are all set. So our first speaker is an N2, Andrew Bruos, and he's going to give us some really interesting information about C-reactive proteins.
My name is Andrew. Hello everybody. My name is Andrew, and over the past 10 or so months of my research fellowship, I've been serving as the role of the data analyst for a number of different positions and lab groups. And for these different endeavors, these different research projects, typically I would come up with a question and then do the analysis, get the results, and then try to pitch it to different doctors. But this was not one of those instances. Here, all the credit goes to Dr. Bikash Jaswal, who is a cardiologist and he reached out trying to understand how he can better help prevent his patients from dying. So really what we did was take a look at a nationally representative cohort of American citizens and apply some filters and then look at some lab values. And that's what we're gonna get into today. So it really goes without saying that heart disease is the #1 killer, and it has been for over 100 years. Since 1921, it has been the #1 killer of US adults. And I think we've all kind of heard the stats before. So in our case, we were specifically looking at CRP, which you can think of it as downstream from inflammation. And then inflammation is downstream of plaques that are causing problems in someone's arteries. And these plaques have the potential to embolize and cause their own downstream problems that would lead someone to potentially die. And in this case, CRP can be measured in the bloodstream, and a low value is less than 1, a high value is greater than 3, and it has been biologically validated in these 3 studies on the right. And within this nationally representative cohort of US citizens that we looked at the CRP levels for, we had to first filter them, and we filtered them based on this risk calculator. And this was based from a 2024 cardiology, just AHA study. And it really just allows for cardiologists to risk stratify their patients and pretty much come up with a very simple answer to say, hey, in 10 years and 30 years, what is your chance of dying? And they can have a reasonable amount of significant confidence in whatever conclusion they have from that. So we applied this same, it's called PREVENT risk calculator score, to our cohort of patients. And then within there, we looked at their CRP levels. And with that, our main research aim was to see if CRP can sharpen the mortality prediction in these patients after we applied this new PREVENT calculator score. Because the PREVENT calculator score does not take into account CRP. And so this nationally representative cohort, it's from NHANES, which is captured by the CDC. It's just a yearly survey in which they try to capture different lab values, demographics, blood pressure, physical exams, so on and so forth, from as many patients as they can. In this case, it was greater than 14,000 patients. And then they follow them over the course of, in this case, the mean follow-up was 10 years. And with that, they can see, did any of these patients die? And if so, when and why? And so we had all of this data to work with. And then you can see the PREVENT tier distribution. So we were mainly focused on that 34% of patients that fall into that borderline intermediate range. Because in our case, and especially from Dr. Vikash Jaswal's interpretation, he says that based on that PREVENT scoring, since you can classify them as low, middle, or high, for the high patients, CRP is not necessarily going to be super useful because they're already very sick and they're going to have like some pretty immediate interventions to help prevent them from dying pretty much. And if they're on the low side, then they're like not that sick, and the odds of them actually dying in the next few years has to be less than 3%. That's just how you get deemed to be in the low category. But it's this borderline intermediate where your chance is 3 to 10% death in the next 10 years that the AHA really just leaves it up to the doctor and says like, hey, this is up to you to decide, like treat it as like individualized care. But that just usually requires the doctors to have to get more information to help inform them to make the best decision. And in this case, our proposal is that CRP could be one of those directions that these doctors take to get more information to help inform them to make the decision. And so here are our results, and the main takeaway was that across the different groups, CRP, like I mentioned, really was only valuable in this middle borderline to intermediate group. There is some other like ways you can interpret the data in which over the course of like 10 years of tracking patients, CRP will have a role to play in not all the years, but more so like towards the later end for the low group. But the main takeaway is that CRP, if it's high in this middle borderline intermediate group, then odds of you dying is increased, and it's significantly going to be increased. And this just kind of paints the same picture. But yeah, we were fairly impressed that our hypothesis was that CRP could be useful in just this middle group, and it turned out that was the only group that had any significance. And here's a survival curve, and the way to interpret these is to look at, on the left side, you can look at the low, and you can see that the lines are pretty straight. That means that these patients are not dying, and this is over the course of 15 or so years. And then on the right side, the high, you can see like that line drops off very fast. That means those patients are dying. And if the free, like the green, yellow, and red lines are all kind of separating, that means that our variable, in this case CRP, is doing a good enough job of like actually separating those patients out. And so you can see in the middle, the borderline intermediate, it doesn't look like those lines are like super separated, but they technically are based on the stats. And they kind of show that regardless, these patients are going to die at some point, perhaps, and the CRP level can help the doctors at different years be able to better infer what their survival probability is. So here's the few like text blurbs for you to read, but in the next like few minutes, I'd like to just discuss about like what could be done from here. I mean, there's only so much, and I guess this is just for everyone in general, just for research. There's a lot that could be done in terms of just like computational work, but then it always comes down to like, what are we gonna do about this? Like, should I or should we perhaps try to validate this in like another external data set, or try to do some cost effectiveness analysis and say like, hey, a $10 CRP would save hospitals this amount of money over time based on these outcomes that we can calculate. Or should I go to actual cardiologists and figure out like, hey, is there anything like we can capture, or like, should we share this information with you like specifically and see what your feedback is? That's kind of where I'm at now. Gonna just take some inspiration and hopefully some discussion either now or after the call just to see what everyone else recommends. But this is kind of just where I'm at for a bunch of different projects where like I can perhaps get some kind of statistical significance and try to publish it into a journal, but I kind of crave like to do more, and I don't exactly know what that looks like, but I'm hopeful that today's DO Day can kind of start some conversations about that. So I'm happy to take any questions as well.
Yeah, I'll ask a question.
Use the mic.
Okay. Thank you again for your presentation. It was very interesting. Do you know by any chance what % of the people studied were women, and of that percentage minority women?
Not off the top of my head, but it's supposed to be I mean, the CDC is in charge, and they would be very transparent about that, but it's really their responsibility to take all 300 plus million US adults and get a cohort that is nationally representative of the population. So yeah, it's definitely an answerable question, but I don't know myself.
Oh, thank you.
I have one question too. That was super educational and very helpful. Thank you so much. This marker, the CRP marker, I don't know if this will be on the scope, but how is that going to help doctors help patients more? Is it pharmacologically advantageous to know the survival rate of it, or when the patient will die?
Yeah, so I mean, the way I interpret it, and I think it's probably best to go, I don't even know which slide would be best, but yeah, regardless, I would say if you have a high CRP, the way I interpret that is that your body has inflammation, and that's not good. And if you have high inflammation, that means the doctor can kind of paint you more so like with bias towards how you would treat this high risk group on the right. And what that typically means is you'd give them a high dose or high intensity statin, versus if it's a low risk, you're gonna go more towards like dietary intervention, lifestyle management, kind of like hands-off approach. But hey, if they're in the borderline intermediate, according to the AHA Prevent, it's up to you. And so when it's up to you, you want to make the care decision that's going to lead to the best outcome. And for those patients, based on if their CRP is like above 3 or whatever, you want to give them a high dose statin, even though AHA technically says the high risk, you only give the high dose statins to them. But I mean, we can't necessarily say you have to give a higher dose statin to these patients that are technically borderline intermediate. This is just like a suggestion that like, hey, the data shows that if you give them or if their CRP is high in this like middle zone, then perhaps you should consider treating them as if they're high risk. Does that make sense?
Thank you.
so much, Andrew, that was great.
Dr. Potter, 1 second, I do apologize for that. Sorry to interrupt. I just wanted to give everyone also a reminder